Hello students. We shall be talking about eating disorders. To start off, what is an eating disorder? An eating disorder is a mental disorder defined by abnormal eating habits that negatively affect a person's physical or mental health. According to the DSM-5, that is Diagnostic and Statistical Manual of Mental Disorders, 5th edition, it has listed 6 disorders under feeding and eating disorders. That is pica, rumination disorder, avoidant restrictive food intake disorder, anorexia nervosa, bulimia nervosa, binge eating disorder, and other specified feeding or eating disorders. The ICD-10 International Classification of Diseases, 10th edition, has listed 8 disorders under the code F50 as eating disorders. First, anorexia nervosa, then atypical anorexia nervosa, bulimia nervosa, atypical bulimia nervosa, overeating associated with psychological disturbances, vomiting associated with psychological disturbances, other eating disorders, and eating disorder unspecified. Now let's look at the prevalence of eating disorders, global and national. Eating disorders have been listed under the Global Burden of Disease Study, that is GBD, making it the 12th leading cause of disability and death worldwide. Among the 306 physical and mental disorders listed in the Global Burden of Diseases Study, eating disorder, particularly anorexia nervosa and bulimia nervosa, have been attributed to affect the female population, who are between the ages 15 to 19 years and approximately 4.5 times more than the male population. Burden was evidently seen in females living in high-income countries, although the relative ranking of burden for eating disorders in low and middle-income countries has gradually increased between the period of 1990 and 2013. Combined, anorexia nervosa and bulimia nervosa were responsible for 1.9 million DALYs, that is disability adjusted life year, which is a measure of overall disease burden expressed as the number of years lost due to ill health, disability, or early death. Indian studies suggest that there exists manifestation of eating disorders in our country. Most importantly, psychogenic vomiting has been reported among females belonging to middle and lower socioeconomic families and in individuals who are the firstborns or the only child in the family. However, eating disorders have been relatively less researched topic in the country and not many studies exist to replicate these findings. Moving on, let's look at the symptomatology of 3 main eating disorders, that is anorexia nervosa, bulimia nervosa, and binge eating disorder. First, anorexia nervosa. The term anorexia means loss of appetite and nervosa indicates the loss is due to an emotional reason or nervousness. The modern name of this disorder, anorexia nervosa, was introduced in the year 1873 by Charles Lessigueux in Paris and William Gill in London. Each established and published their work in this area independently. If we try to understand the clinical description of this disorder, it proves to be quite unique and quite different the case. As the name suggests, a loss of appetite is barely the underlying problem in this disorder. Rather, the individuals suffer from anorexia nervosa and are gripped with an intense fear of gaining weight or becoming fat and display behaviors to have a low body weight. Now, I would like to direct your attention to the diagnostic criteria of anorexia nervosa displayed on the screen. As we have seen earlier, becoming and being thin is the primary goal for the people with anorexia nervosa. However, their motivation to be and stay thin stems from the fear of becoming fat or obese. They are afraid of their desire of devouring great amounts of food and of losing control over the size and shape of their bodies. Despite their focus on thinness and their severe restrictions on food intake, it would be surprising to know that people with anorexia are preoccupied with food. They may spend considerable amount of time thinking and even reading about food and planning their limited meals. Many report that their dreams are filled with images of food and eating. This preoccupation or uncurbed desire for food can be accounted for food deprivation itself, thus making these desires the effect of deprivation rather than the cause. Individuals suffering from anorexia nervosa also tend to have distorted thinking and have a low opinion on their body shape and size, considering themselves to be unattractive and undesirable. While thinking low about their body size and shape holds true, they also tend to overestimate their body size, leading to their body image distortions. These distortions about their body image tend to become maladaptive attitudes and misperceptions, leading them to hold beliefs such as, I must be perfect in every way, I avoid guilt by not eating, an imperfect body reflects an imperfect person. Another client quotes saying, I have a rule when I weigh myself. If I have gained, then I starve the rest of the day. But if I have lost, I starve anyway. Anorexia nervosa typically begins between the early and middle teenage years, often after an episode of dieting or after a recurrence or an occurrence of a life stress. Lifetime prevalence of anorexia is less than 1% and it is at least 10 times more frequent in women than in men. This drastic gender difference in the prevalence of the disorder is mostly because of the greater cultural emphasis on women's beauty, which has promoted a thin shape as the ideal over the past several decades. The starvation habits of anorexia nervosa cause medical problems such as amenorrhea, that is the absence of menstrual cycles, lowered body temperature, lowered blood pressure, body swelling, reduced bone mineral density, and slow heart rate. Metabolic and electrolyte imbalances are also common. And sometimes it can lead to death by heart failure or circulatory collapse. The poor nutrition of people with anorexia nervosa may also cause skin to become rough, dry, and cracked. Gastrointestinal problems, mild anemia, nails becoming brittle, and hands and feet becoming cold and discolored are quite common in this disorder. Some people have loss of hair from the scalp and some grow lanugo, that is the fine silky hair that covers some newborns on their trunk areas, extremities, and face regions. Individuals diagnosed with anorexia nervosa could also have other comorbid conditions such as depression, anxiety, low self-esteem, and insomnia or other sleep disturbances. They may also have issues with substance abuse and may display obsessive compulsive patterns such as cutting their vegetables in particular shapes and having certain strict rules for food preparation and prioritizing exercise above all the other activities in their lives. Though anorexia nervosa is a life-threatening disorder, with the right treatment, recovery is possible and 50 to 70% of people gradually recover. However, recovery often takes 6 to 7 years and relapses are common before a stable pattern of eating and weight maintenance is achieved. Now, we shall move on to the second eating disorder in our discussion, that is bulimia nervosa and its clinical picture. Bulimia nervosa, also called binge-purge syndrome, is characterized by uncontrolled binge eating and efforts to prevent weight gain by using inappropriate behaviors such as self-induced vomiting and excessive exercise. Binge eating refers to eating a large amount of food in a small amount of time, and inappropriate behaviors here I refer to are purging, which is an attempt to get rid of the food consumed. The term bulimia was first coined by G.F.M. Russell, a British psychiatrist, and the term was later adopted into DSM in the year 1987. The term bulimia is derived from a Greek word bos, which means ox, and limios, which means hunger, meaning hunger of such proportions that the person can eat an ox. Now, I would like to direct your attention to the diagnostic criteria of bulimia nervosa displayed on the screen. The clinical picture of bulimia nervosa shows that bulimia typically begins with restricted food intake to maintain a slender body shape. During these early stages of food restriction, people usually start off with taking low-calorie foods, but after a certain period of time, they gradually stop taking these foods and they move on to forbidden foods such as junk foods like potato chips, chocolate, pizza, cake, etc. These people on an average binge can consume up to 4,800 calories. After the binge is over, in an effort to manage their lack of self-control, the person begins to vomit, fast or exercise excessively or abuse laxatives. Though their behavior disgusts them, people suffer with bulimia nervosa tend to repeat this pattern, and these behaviors of purging alleviate their fear of gaining weight that comes from the eating. People with bulimia nervosa may have between 1 to 30 binge episodes per week. DSM describes binging to have two characteristics. Firstly, it involves eating an excessive amount of food with minimal chewing within a short period of time. And secondly, it involves a feeling of being powerless and losing control over eating, as if one cannot stop and is out of control. Binging among people with bulimia is often a secret act and is often concealed due to shame and guilt. These episodes are usually triggered by stress and negative emotions and are only subsided when the person is uncomfortably full. Binging is often reported by people as losing control to that extent where the person feels that they are in a trance-like state and they have no awareness of their behavior during binging. As these urges of binging are associated with great tension, merely satisfying them would provide relief to the person. However, these acts of binging leave the person with feelings of extreme self-shame, self-blame, guilt, and depression, as well as fears of gaining weight and being discovered. As an attempt in the purging activities undertaken by people who have bulimia nervosa, people tend to induce vomitings by gagging themselves, and people with bulimia nervosa can induce vomiting without gagging as well. However, due to forced vomiting of the food, the person's ability to feel satiated can be greatly affected, and this can lead to frequent and great urges for binging. Though these acts of purging do relieve the person of feeling of the fullness and negative emotions of guilt and shame, but eventually they develop a cycle of purging which gives way to more binging and more purging, making the people feel powerless and disgusted with themselves and out of control. By this time, most of the people realize that they have an eating disorder. Although bulimia nervosa typically begins in the late adolescence or early adulthood, they can persist into late adulthood and middle age as well. Evidence suggests that bulimia nervosa is comorbid with other diagnoses such as depression, personality disorders, anxiety disorders, substance use disorders, and conduct disorder. The side effects that are seen in persons with anorexia, such as menstrual irregulations due to recurrent vomiting or amenorrhea, may occur in persons with bulimia nervosa as well. However, people with bulimia tend to have a normal body mass index or are slightly overweight but never underweight as people with anorexia nervosa. Also, side effects include swollen salivary glands, tearing of stomach and throat tissue, and a loss of dental enamel as stomach acids affect the teeth during periods of repeated purging by vomiting. Though the fear of gaining weight remains the common factor in both anorexia nervosa and bulimia nervosa, the key difference between the two is weight loss. People with anorexia nervosa tend to lose a tremendous amount of weight, whereas people with bulimia nervosa do not. However, about 75% of the people recover, and better prognosis is after the diagnosis, especially after a few years of the onset of the disorder. People with binge eating disorder engage in repeated eating binges during which they feel no control over their eating. Binge eating disorder was recently categorized as a separate psychiatric disorder as it is recognized as a pattern common among many overweight people. The binges are frequent and recurrent. They are characterized by a lack of control over eating and distress about binging, rapid eating, and eating alone. Binge eating disorder is distinguished from anorexia nervosa by absence of weight gain and from bulimia nervosa by absence of compensatory behaviors. Now, I would like to direct your attention again to the screen to see the diagnostic criteria of binge eating disorder. persons with binge eating disorder, the frequent episodes of binging lead clients to become overweight and even obese. However, not that everyone who is obese has a binge eating disorder. The binges that occur in binge eating disorder are similar to binges that occur in bulimia nervosa. However, as discussed earlier, it is differentiated from bulimia by the absence of purging or compensatory behaviors after a binging episode. But people with binge eating disorder are not wholly driven by thinness, as the patients with bulimia nervosa and anorexia nervosa. However, symptoms such as preoccupation with food, weight and appearance, of evaluation of self largely based on their weight and shape of the body, misperceptions of their body size, being extremely dissatisfied with their body, potential risks of substance abuse are common among binge eating disorder patients as well. Although not full-blown, struggling with feelings of depression, anxiety and perfectionism, impaired social functioning, low self-esteem are also seen among these patients. Evidence has not shown much of a gender difference in the prevalence of binge eating disorder. Many of the physical consequences stem from the potential risks posed by being overweight and obese, such as increased risk for type 2 diabetes, cardiovascular problems, breathing problems, insomnia, joint muscle problems, and other problems such as depression or irritable bowel syndrome or sleeping disorders, and for women, irregular menstruation cycles or an early onset of menstruation is common. Now, let's look at the causal factors of these eating disorders. Firstly, the biological causal factors. The tendency to develop an eating disorder runs in families, and the biological relatives of people with disorders are at high risk of developing the disorder. Relatives of those with anorexia nervosa are at increased risk to develop OCD or obsessive compulsive personality disorder, alcohol and drug dependence, etc. Twin studies also suggest that both anorexia nervosa and bulimia nervosa are heritable disorders. Though not robust findings, evidence of chromosome 1 and chromosome 10 being linked with susceptibility of anorexia nervosa and self-induced vomiting in bulimia nervosa respectively have been reported. Findings on the role of neurotransmitter serotonin in developing eating disorders suggests that serotonin plays an important role in regulating eating behaviors along with the mood of an individual. Furthermore, damage to the frontal and the temporal cortex in the brain is linked with developing anorexia nervosa and bulimia nervosa in some. This is interesting because the temporal cortex is known to be involved in body image perceptions, and parts of the frontal cortex, that is the orbitofrontal cortex, also play an important role in monitoring the pleasantness of stimuli such as the smell and taste of food. The glossy, glamorous fashion magazine covers and different film industries across the globe advocate the false notions of the shape and size of women. Models are shown in unrealistically thin shapes and sizes, and major consumers of these magazines are young women, imposing upon themselves social pressures of becoming thin. These socio-cultural pressures can lead to negative body image among young girls and women, resulting in high intrusive perceptual biases regarding how fat they are. However, if societies that place an emphasis on being thin were to emphasize and influence every single person, eating disorders would be much more prevalent and common than they are today. Family influences. Evidence suggests that families of patients with eating disorders are dysfunctional, which is a contributing factor to the development of these disorders. Studies suggest that patients with anorexia nervosa perceive their families as more rigid, less cohesive, and as having poorer communication than healthy control participants do. In addition, many of the parents of patients with eating disorders tend to have a perfectionist tendencies regarding the desirability of thinness, dieting, and physical appearance. Fairbairn and colleagues have noted that women with bulimia nervosa reported of risk factors such as high parental expectations, often other members of the family also dieting, and degree of critical comments from their family members about shape, weight, or eating. Also, looking at it the other way around, having an individual with an eating disorder in the family is more likely to affect the family's functioning in a negative way. Gender. Gender plays an important role in eating disorders, making women more vulnerable than men. It can be listed as one of the major risk factors of developing eating disorders, particularly anorexia nervosa and bulimia nervosa. Whereas among men, their sexual orientation is a risk factor in itself for disorderly eating. Thus, we can see binge eating is typically seen in men than in women. Internalization. Internalizing the thin ideal can result in body dissatisfaction, dieting, and create a negative affect, which can in turn cause an eating disorder. Perfectionism. Perfectionism can be defined as the pursuit of unattainable high standards combined with an intolerance of mistakes. It has long been regarded as an important factor for eating disorders. This is because people with perfectionism may have much more probability to subscribe to the thin ideal and relentlessly pursue the perfect body. Now, dieting is also a common phenomena that happens when people wish to become thinner, and usually many eating disorders begin with the sole notion of dieting. Though dieting is in itself may not be a real problem, people who want to lose weight are the people who are usually unhappy and their bodies are most inclined to feeling negatively about themselves when they fail to stick to their diet plans. Negative emotionality or negative affect, that is, feeling bad about oneself. This is also seen as a risk factor for body dissatisfaction. When a person feels bad about himself or herself, they tend to become very self-critical and majorly focus on their limitations and shortcomings and magnify their flaws and defects. As we have seen earlier, cognitive distortions such as I am fat, I am a failure, I am useless have the potential to make people feel worse about themselves. Patients with eating disorders are often very conflicted about getting well. Approximately 17% of the patients with severe eating disorders have to be committed to a hospital for treatment against their will. The present-day treatment strikes the right balance between treating psychological as well as the physiological aspects related to these disorders to yield better results for the patient. Thus, with the medical complications being dealt with, the psychological treatment can also be carried out aiming towards complete recovery. Although hospitalization is frequently required for close monitoring in the initial phases of treatment and recovery, in extreme cases of eating disorders, the role of family and friends to gain complete recovery is very much needed. In treating anorexia nervosa, hospitalization, monitoring of gradual increase in food intake, and careful observation is much needed. Other immediate medical treatments such as tube or intravenous feeding to restore electrolyte imbalances, malnutrition, etc. are also carried out. Treating anorexia nervosa is a two-tiered process. The first goal, that is, to immediately help the person ingest food and gain weight in order to avoid medical complications and the possibility of death. This can be achieved by operant conditioning behavior therapy programs, which have been somewhat successful in achieving weight gain in a brief period of time. Here, the therapists using behavioral weight restoration approaches offer rewards whenever patients eat properly or gain weight, and offer no rewards when they eat improperly or fail to gain weight. As the reinforcers are distinguished into two types, the first, drive reduction, and the second, affective and motivational aspects. Here, the affective and motivational aspects of the reinforcers act as a motivating factor for the client towards regaining their body weight and strength for the second phase of the treatment. The second goal of the treatment, that is a long-term maintenance of weight gain, remains a challenge in the field. For the second goal of the treatment, cognitive behavioral therapy can be employed to change behavior and maladaptive styles of thinking among clients with eating disorders. Such techniques are designed to help the clients appreciate and alter the behaviors and thoughts on the behavioral side. Clients are typically required to monitor, perhaps by keeping a diary, their feelings, their hunger levels and food intake and ties between these three variables. On the cognitive side, they are taught to identify their core pathology, the deep-seated belief that they should be judged by their shape and weight and by their ability to control their physical characteristics. The clients may also be taught alternative ways of coping with stress and by solving problems. Thus, the treatment majorly focuses on modifying distorted beliefs concerning weight and food, as well as distorted beliefs about the self that may have contributed to the disorder. CBT has proved very effective in treating anorexia nervosa as well as bulimia nervosa, as these disorders have shared features. However, though combined hospital treatment and CBT found improvement in the symptoms of anorexia for up to 1 year after the treatment procedure, this has been very difficult as the patients with anorexia nervosa have extreme cognitive rigidity. This calls for new treatment developments in the field. Treatment procedure of weight restoration has been the nutritional rehabilitation program, which is a combination of supportive nursing care, nutritional counseling and relatively high-calorie diet. Here, nurses gradually increase a patient's diet over the course of several weeks to more than 3,000 calories a day, and the nurses educate the patients about the program, track their progress, provide encouragement and help them recognize that their weight gain is under control and will not lead to obesity. In some programs, the nurses may also provide motivational interviewing and intervention in which they motivate the clients actively to make and follow constructive choices regarding their eating behaviors and their lives. Studies find that patients in nursing care programs usually gain the necessary weight over 8 to 12 weeks. Moving to family therapy, it is considered to be the treatment of choice for anorexia based on this notion that interactions among members of the patient's family can play a role in treating the disorder. It is known as the Maudsley model, where the treatment doesn't hold either the parent or the child responsible for developing anorexia nervosa. This treatment program involves 10 to 20 sessions spaced across 6 to 12 months, and the treatment works in 3 phases. In the refeeding phase, the therapist works with the parents and supports their efforts to help their child to eat healthily once more. Family meals are observed by the therapist and efforts are made to guide the parents as a functional support team for their daughter's recovery, considering that this disorder affects most females. After the patient starts to gain weight, the negotiations for a new pattern of relationships phase begins, and family issues and problems begin to be addressed. Later, in the termination phase of treatment, the focus is on the development of more healthy relationships between the patient and her parents. Cognitive behavioral therapy is the best validated and most current standard for treating bulimia nervosa. In this therapy, firstly, people with bulimia nervosa are questioned and challenged about the set standards of the society for physical attractiveness. Now, the behavioral component of CBT, that is cognitive behavioral therapy for bulimia nervosa, focuses on normalizing eating patterns. This includes activities such as meal planning, nutritional education, and ending binging and purging cycles by teaching the person to eat small amounts of food more regularly and also teaching them that all efforts are not lost. The cognitive element of this treatment is aimed at changing the cognitions and behaviors that initiate or those thoughts which persuade a binge cycle. This is accomplished by challenging the dysfunctional thought patterns typically present in bulimia nervosa, such as all or none thinking or dichotomous thinking. For instance, we shall see the applications of CBT in one of the aspects of treating bulimia. The therapist challenges the patient's tendency to divide all foods into good and bad categories. This is done by providing factual information as well as by arranging for the patients to demonstrate to themselves that taking bad food does not inevitably lead to a total loss of control over eating. Also, relaxation is employed to control the urge to induce vomiting. The therapist and the patient work together to identify events, thoughts, and feelings that trigger an urge to binge. They then learn more adaptive ways to cope with these situations. And patients also tend to learn assertiveness skills, which helps them cope with unreasonable demands placed on them by others, as well as more satisfying ways of relating to other people. Though treatment with CBT clearly helps to reduce the severity of symptoms in patients suffering with bulimia nervosa, to an extent, patients are rarely entirely well at the end of the treatment. Thus, even after treatment, weight and shape concerns may remain. However, research indicates that CBT alone has proved to be more effective than any available drug treatment. However, when cognitive behavioral therapy is tailor-made, that is, approaches that are specifically tailored to the needs of the patients as opposed to the standardized treatment format, it has yielded beneficiary results for these patients. New approaches such as dialectic behavioral therapy, which is a treatment used for borderline personality disorder, it has also been explored in this area and has proved to have some success. Due to the high level of comorbidity between binge eating disorder and depression, antidepressant medications are sometimes used to treat this disorder. Other categories of medications such as appetite suppressants and anticonvulsants have also been focused and have yielded better results. Therapies such as interpersonal psychotherapy, cognitive behavioral therapy, and behavioral weight loss treatment could also be used. As the classification of binge eating disorder as an independent disorder is relatively new, not many studies exist on the various treatment plans for this disorder. As we know, prevention is better than cure. Intervening with the potential target group, that is children or adolescents, before the onset of eating disorders may help to prevent these disorders from ever developing. Psychoeducation approaches. These approaches focus on educating children and adolescents about eating disorders in order to prevent them from developing the symptoms. Second, de-emphasizing socio-cultural influences. This focuses on helping children and adolescents resist or reject socio-cultural pressures to be thin. Third, risk factor approach. The focus here is on identifying people with known risk factors for developing eating disorders. Examples: people showing more concerns about their body image, dietary restraints, weight, etc., and interventions to alter these factors at the earliest.